I'd like to welcome you all in our second international conference of inborn error of metabolism at the genetics department at Shams University. This is a part of the 42nd International Medical Congress of Ain Shams University, which showed the subject maple syrup urine disease. We'll hear about the clinical spectrum, diagnosis, management, challenging in diagnosis and few challenging cases, genotype-phenotype correlation, and the expert opinion of Egyptian experience, the dietary management, and some case presentation. We are honored to start with the first presentation by Dr. Zuhair Al-Hasnan. Dr. Zuhair is a consultant genetist at the Department of Medical Genomics and the Department of Translation Genomics Center of Genomic Medicine at King Faisal Specialized Hospital, Saudi Arabia. Dr. Hasnan has served in several prominent committees with leading national role. He was the chairman of a research ethical committee at King Faisal and the director of Saudi National Newborn Screening Program, the deputy chairman of the National Committee of Bioethics. This is not all. Dr. Hasnan also has a great interest in literature. He's a poet and a novelist. Dr. Hasnan's presentation will be titled The Clinical Spectrum and Diagnosis. Please start, Dr. Hasnan.
Bismillah ar-Rahman ar-Rahim. Can you hear me?
Yes.
Okay. Slides are clear?
Not yet.
Professor Zuhair, please share your slides. You haven't shared it yet.
You can't see it now?
Yes.
Okay. Bismillah ar-Rahman ar-Rahim. I would like first to thank the organizers for this kind invitation. Special thanks to Dr. Ula. It's really a pleasure to be part of this conference. And I would like to start with a very dear personal story about MSUD. I had the opportunity of doing my fellowship in the States at Johns Hopkins. And I knew then at the beginning of the fellowship that MSUD is a common disease in our country. So I wanted to see MSUD patients in the hospital to see how people are managing these patients. And I waited and waited and waited to see a single case. And the 3 years of fellowship was spent, and I had only the chance of seeing a single MSUD patient. And when I came back and practiced as a geneticist in our hospital, I saw 3 cases in the first week. So 3 years just to see a single case, and in 1 week I saw three cases, just to see the magnitude of the problem. And you then, that Lancaster County, where the Mennonites are, have the high incidence of MSUD. So I had the pleasure of visiting the place and see the very interesting community there with a great appreciation to Richard Kelly for arranging this visit. It was very, very interesting. And I would like to be excused if if I'm not going to present the spectrum and diagnosis as we would like it to be. And I think this is an opportunity for me to share the clinical experience that we have in King Faisal, especially in the presence of an authority and reference in the MSUD management, Professor Strauss, and to see the contrast of the management in the Mennonites compared to the management that we have in King Faisal and in Saudi Arabia, as well as in the presence of expert group of managing patients with MSUD in Egypt. So at the beginning, I will introduce about the topic very briefly, and then I will go to the lessons that we've learned over the years from the management of MSUD in our hospital. So this is just a typical presentation of an MSUD case, a classic MSUD case, in which the baby is usually having a free symptom period of, or symptom-free period of about 5 days, that then the baby presents with poor feeding that progresses to coma, with hypertonic episodes, with opisthotonus, boxing and pedaling movements, and sometimes mothers would tell these very important and revealing manifestations at the beginning of the disease, and the abnormal smell. So typically these patients will end up in the emergency room, managed by ER physician and general pediatricians. And when these babies are subjected to investigations, typically routine investigations will not be revealing. And that's why it is a very tough disease to detect unless you have very high index of suspicion and very good background knowledge about the presentation of the condition. So this is a typical presentation of a classic maple syrup urine disease, which is due to the deficiency of the branch chain ketoacid dehydrogenase. Now, the revealing findings that are very important to physicians who are not in the field: the symptom-free period, the poor feeding that progresses to coma, the abnormal tone, abnormal movements, and the abnormal odor that is easily recognizable. And in regions where consanguinity is common, we have large family size, multiple members are affected, family history can give you a very good clue to what is going on. And I cannot endorse further the excellent presentation and data by Professor Strauss and his team. And these are just two examples of amazing resources for MSUD. And I would highly recommend that anyone who would like to learn about MSUD, just read these two, and among many other publications by the group in Lancaster that had really enriched our knowledge about MSUD. And the first few slides of the presentation will be just an extract from their experience, and then I will move to our clinical experience in King Faisal. So this is an autosomal recessive disease. It's rare in non-consanguineous populations with an estimated incidence of 1 in 185,000, even to much less than this. And the Mennonites have the highest incidence with 1 in 380 live births due to the founder mutation with the carrier frequency of 1 in 10. And in the region, because of the consanguinity, MSUD is not an exception. So in Saudi Arabia, the incidence is 1 in 15,000. In Egypt, at least this is the data that I have from literature, and please correct me if this is not accurate, is 1 in 25,000. In Kuwait, it is 1 in 59,000. So relatively compared to the non-consanguineous population, we have a higher incidence of this recessive disease. Now, again, this is from Strauss's presentation and review. The presentation of the classic MSUD can happen during the first 12 hours with the smell in the serum, and during the first 24 hours, elevated branch chain amino acids and allo-isoleucine, 2 to 3 days, ketonuria, irritability, and poor feeding that can progress to encephalopathy, lethargy, apnea, obstructive stereotyped movements, and then 7 to 10 days coma, central respiratory failure. And there are 4 types, and the most common one is the classic one, in which you would expect to see severe deficiency of the enzyme, and there is a rough correlation between the phenotype and the biochemical, the type and the biochemical phenotype, in which the enzyme deficiency is severe in the classic and much milder in the thymic responsive. Likewise, the clinical features vary between the classic, intermediate, intermittent, and thymic responsive. The intermittent intermittent is characterized by episodic decompensation, whereas the intermediate and thymic responsive have the odor, the irritability, the growth failure, the developmental delay, and these can be missed if you do not have high index of suspicion, if you do not subject these patients to screening. Likewise, the biochemical signs with elevated branch chain amino acids correlate with the type. So if you have an intermittent, you would expect to see normal branch chain amino acids in between the crisis, whereas in patients with the classic, you will see during the presentation. Now, the diagnoses are by clinical features, elevated plasma branch chain amino acids, and the presence of the allo-isoleucine, and the urinary secretion of the branch chain hydroxy acids and the keto acids. The odor, which is very characteristic in this condition, is found in maple syrup, which does not exist in this region, and then in fenugreek. It is very interesting to know that there was a letter addressed to New England Journal of Medicine about an Egyptian 5-week-old Egyptian infant who had a 10-minute episode of unconsciousness while drinking bottled tea. And the diagnosis was made as false positive maple syrup disease. And what was found is that the parents mentioned that they had given their child a herbal tea, hilba, to reduce flatulence and prevent fever. So in our region, when we counseled these patients, we mentioned that the smell is very similar to hilba, which is something that is well known in the region. In the newborn screening, we utilize the leucine and isoleucine concentration, in addition to the ratio of leucine-alanine and leucine and phenylalanine, and these have been adopted widely worldwide and in our newborn screening program. So the absolute value is not enough. These are the 3 genes involved in the classic ones, and I'm not addressing the E3 phenotypes. And according to the human gene mutation databases, these are the statistics associated with the number of mutations in these 3 genes. And you could see mutations in any one of these genes, and you cannot clinically distinguish which is which, with the exception of the E3. Now, I will move now to the MSUD experience of management in Saudi Arabia, with a focus on the management of MSUD in our hospital, which is the major tertiary referral center for metabolic diseases for the past 40 years. In the country, we screen for 19 genetic conditions, and MSUD is one of them. Officially, the newborn screening program had been launched in 2005, but pilot studies and early screening had started in the 1990s. And the incidence, as I mentioned earlier, is 1 in 15,000. And MSUD, MMA, and propionic acidemia are the top metabolic conditions that we see in the region. Just to have an idea of the genotype distribution of MSUD in our population, and this is, I think, is very relevant since Arabia is the resident of tribes for the past millennia, and therefore the expansion of these Arab tribes to the neighboring Arab countries, including Syria, Iraq, Yemen, Egypt, North Africa, had also shown the migration of these seeds of variants into the other regions. However, we have not seen a major founder mutation in our population, and MSUD is seen across the country. Whereas, for example, in arginosuccinic acidemia, there is a major founder mutation in a very specific area in a single tribe in the country that made arginosuccinic acidemia relatively, compared to the other populations, extremely common. So if you compare, for example, arginosuccinic, where you have a founder mutation in Saudi Arabia compared to the States, we're at least 30 times more common. MSUD is 10 times. And the main reason is that we do not have a major founder mutation. And therefore, most likely that these mutations are not very ancient Arab mutations. However, the neighboring countries may observe the same variants with the expansion of the tribes, with migration with the Islamic expansions outside the Arabian Peninsula around 1400 years ago. If you look at the genotype data in Saudi Arabia, again, very similar to the international data, distributed across the different genes, and there are at least 20 mutations. So it is genetically heterogeneous, and we have not observed an apparent genotype-phenotype correlation in our population. Now, in our country, the history goes back to the pilot study that was initiated by Dr. Muhammad Rashid in the 1990s, where he established the MSMS-based neonatal study that had identified the frequency of almost 1 in 1,000. And that was the basis of the expanded newborn screening utilizing tandem MS, the work that has been, the seminal work that has been done by Dr. Rashid as well as Millington, and therefore they had been awarded Guthrie Award. So the hospital had been managing MCD cases for almost the past 40 years. And many of these cases had been either diagnosed and then managed in other hospitals. Currently, we have 88 active cases. And over the years, other neighboring hospitals in the region had also inherited some of these cases that are detected by newborn screening. So over the years, we're seeing more and more of excellent services, either in Riyadh region or in other regions in Saudi Arabia. So as I mentioned, several regions have seen MCD cases with different genotypes. And therefore, many of these cases had been referred to our center over the past 40 years for management, where the facility of diagnostic and nutrition as well as a clinical management is. Now, what have we learned over the years of managing these cases? And I would like to share this, and I hope that we have time during the discussion where we can see whether we need to have a modification of what we have seen over the past 40 years in terms of managing these patients. Now, in the ER, there are common pitfalls in crisis management, and these are commonly observed in local hospitals where these cases present either as a neonate or as a recurrent crisis. Now, prolonged protein restriction is very commonly observed, where pediatricians tend to keep these patients on IV fluid for a prolonged period of time, with a fear that introducing protein can increase the crisis further. There is also a delay in the isoleucine and valine supplementation during the crisis. Overlooked early nutrition support, and I think it is extremely important to engage expert, and I would like to highlight the importance of having an expert dietitian from hour zero. This is a disease that we do not have medications for. It is not like organic aciduria or urea cycle, where you can use scavenger. It is pure nutritional management and supportive care, and therefore nutrition is extremely important to be addressed from the first moment. Lack of proper monitoring of sodium and osmolality is commonly observed. The use of hypotonic fluid is commonly observed. And the sense of reassuring routine chemistry when these children come to the emergency room and blood gases, CBC, renal, liver function tests are all fine, whereas the patient has the leucine of more than 1,000 and he's encephalopathic. And this sense of reassuring will delay the management and will lead in many instances to the development of the serious complication of cerebral edema, which can have very mild symptoms and signs at the beginning of the presentation. This is extremely, extremely important to be appreciated. In addition, what we have observed over the years is that adult presentation can be extremely tricky. They have very unusual manifestations, hallucinations, aggressive behavior, ataxia. This is a CT scan of an unfortunate young man who presented to the emergency room with just hallucination. He was walking and ended up having severe cerebral edema that unfortunately did not respond to aggressive management, ended up in herniation and death. So this can be very tricky and very deceiving in adult presentation compared to neonates and younger children. And therefore, mild symptoms in older children and adult patients should be carefully assessed, because there is no good correlation between the clinical presentation and biochemical values of the leucine, at least in the early phases of the crisis. And this may delay the prompt recognition of the seriousness of the disease and the crisis, as well as the management. And since most of the physicians that are treating MSUD patients globally are pediatricians by training, we do have inadequate awareness among our colleagues in adult medicine, in ER, ICU, in internal medicine, of how these conditions can present and how serious these crises can be, especially in patients who only present with very mild early signs and symptoms of just hallucination or ataxia, talking to you, sitting on the chair, communicating very well, and then very quickly you lose the patient in severe cerebral edema because you have not introduced the proper management very early on. This is really, really serious. Now, do we really need leucine in the emergency room? Is it a must? Now, I think knowing the fact that in many places, leucine assessment by biochemical testing is not available, it's not ready. It's not where you could have it within few hours in many hospitals. And therefore, management should not be delayed pending results. Crises happen in many situations in local and remote areas. So the clinical judgment with very low threshold for initiating full-scale management is the gold standard. And there should be availability of 24/7 consultation services with experts in metabolic diseases. My patients who are being managed for many years in our center, they live outside King Faisal, outside Riyadh, in remote areas where they can have a crisis in a small hospital where expertise is lacking, and therefore we should have a 24/7 consultation service and advice for our colleagues in order to help these patients. And therefore, because of the complication and seriousness of the illness during the crisis, I think stabilization and immediate transfer to a tertiary facility is very important in my opinion. Now, again, leucine in the emergency room. Should we care about the absolute value or the relative value? Now, I think what we have observed over the years is that leucine level compared to baseline is very critical. If you compare case 1 to case 2, and in the emergency presentation, 1,000 is something that is alarming compared to the 900. But if you compare to the baseline, you wouldn't expect a significant manifestations in case 1 because the baseline is already high compared to case 2, in which the baseline is very low. And therefore, knowing your baseline is very important in order to judge how aggressive you should be in the management. Now, the question that always comes in patients with MSUD crisis is, should we dialyze? And I know the experience of Professor Strauss and his team would suggest that dialysis may not be utilized, and they have shown excellent outcome without the use of dialysis. But in general, what we have recommended over the years is that in case of severe, quote unquote, crisis, dialysis should be considered, and hemodialysis is preferred with adequate nutrition to overcome catabolism from the beginning. And the judgment whether we're dealing with severe crisis or not severe crisis is a clinical judgment and maybe biochemical. But I think it's a clinical judgment by an expert physician. And if we are in doubt, consider the crisis severe until proven otherwise. In the nursery. Now, it's quite common to see in our population and many populations in the region where we have large families, to see another child who is affected with MSUD. Now, so the parents of a child with MSUD who's been followed up in our clinic is expecting to have a new baby. And this baby did not have a prenatal testing. So we're not sure that the baby is affected or not. What is the advice? Should we challenge the baby or should we do screening from the beginning? And what we have devised as a protocol of the management for these babies is to challenge with the regular formula for the first 24 hours. And immediately at 24 hours, we take the sample for screening, start MSUD formula, and if the result is positive, continue. If negative, resume normal feeding with a close observation that you may have, just in case you may have a false negative at the beginning, especially if the baby did not have adequate intake during the first 24 hours. So we should be cautious. But the challenge, the very well controlled challenge is important. Transplant or not to transplant. Now, the data that had accumulated again from the group and Professor Strauss's team suggests that liver transplant had made a significant impact on the outcome of these cases. The plasma leucine, isoleucine, and valine concentration normalized within 6 hours after transplant and remained on an unrestricted diet. And the tolerance increased tenfold. There is a clinical instability even during intercurrent illness. However, there is no reversal of cognitive disability or psychiatric illness. This is expected. There is a rest of progression of neurocognitive impairment, which is something that is should highly be looked at when we counsel these patients. And then prevention of life-threatening cerebral edema is also very important. Good outcome of liver transplant. In our hospital, we have developed guidelines for management of patients of MSUD. The liver transplant guidelines are pre and post. And among the guidelines, we wanted to do as a preemptive measure to transplant these patients in affected infants if a severe phenotype expected based on family history of a severely affected sibling, or a genotype known to cause a severe form of MSUD. And over the years, we have transplanted 17 cases, and we've used 7 of them as domino transplant for other conditions. And what we have observed is that the families have been very satisfied after the transplant, better quality of life. There is no more restriction. There is a freedom. They now feel the freedom, which is psychologically very important for these families. And they have also the sense of no more crisis. So this very anxious life is no longer there because of the lack of or the elimination of the crisis post liver transplant in many cases. However, we should not give the false impression to the families that this is a cure. This is not a cure. It's replacing a disease with probably a milder one. And I would like to conclude by the importance of prevention. And therefore, our center has been very aggressive in adopting preventive interventions for these cases: prenatal diagnosis, pre-implantation genetic diagnosis, extended family screening for at-risk family members. We have large families, consanguineous. They continue to get married with their cousins in spite of counseling, and therefore addressing the carrier status of these families in order to prevent the recurrence of the tragedy in a future child is extremely important. Our center is one of the largest in the world that provide PGD, and many families had benefited from this technique. And also, we have also utilized the permission from the Council of Senior Scholars that would say, yes, go ahead and terminate conditions, provided that these conditions are incompatible with life, or conditions that cause disability, which is severe, permanent, and incurable, as long as you're doing it within 120 days. So we've been adopting this fatwa to offer termination of pregnancy for our families. Emergency management guidelines are available online, and we have developed ones that are available free, and you can access it. And if you have any comments and suggestions on the guidelines, please feel free to communicate with me, and I'll be happy to review and adjust the guidelines accordingly. Thank you very much.
Thank you, Dr. Zuhair, for this presentation. I should be the second speaker. Can I share my screen?
It's a great pleasure to introduce Professor Sulaf Mohammed Al-Sayed, the head of the Medical Genetic Department, Faculty of Medicine at Ain Shams University. She will present an interesting MECD case with a challenging diagnosis. Please, Professor Sulaf, the floor is yours.
Thank you, Dr. Ala. I chose this case to present or to highlight the challenges that we see every day in our clinic, whether MSUD or not. This case is actually an old case that came to the clinic nearly 7 or 8 years ago. As we know, neurometabolic disorders are those disorders where neurological symptoms predominate, especially convulsions, and other symptoms like poor feeding, vomiting, and lethargy also included. All these symptoms are non-specific and overlapping with many other diseases, and therefore it is difficult to diagnose which of these neurometabolic disorders. And it needs some specialized investigation in highly specialized laboratory, which is not available all the times. This family came to us referred because of repeated infant death. They had 3 children. They are consanguineous family, double consanguinity, double cousins, and they had 3 children, 2 girls and 1 boy, with convulsion that starts few hours after birth. They also had failure to thrive that ended by their death after few months. Then they had another child, 4th child, who was normal till the age of 6 months. This girl, she had normal development. Then she started to develop hypotonia, progressive loss of previously acquired milestones, and convulsions that ended by her death at the age of 14 months. The first challenge that we face in Egypt is that we have to do genetic counseling with no available investigation. The parents didn't have any investigation of the previous 4 children. So we counseled the parents that they may be carrier of 2 recessive diseases, because there is 2 different presentation, 3 with immediate convulsion in the first few days of life, and another child who had normal or a period of normality for 6 months. Because Tay-Sachs disease is one of the most common in neurometabolic disorders, and because of the history of the 4th child, we suggested that this is Tay-Sachs disease. And because there was at that time there was availability of the carrier testing by enzyme, so we suggested that the parents should be tested for the carrier status for Tay-Sachs disease. We didn't have at this time molecular testing. We had only enzyme assay. So we started with the mother. After counseling the family, the father said that the mother should be tested first, and it revealed reduced leukocyte plasma activity of hexosaminidase A enzyme, indicating a carrier status of Tay-Sachs disease. The father refused to do any test. And as I said, because molecular test was not available and we have to send the sample outside Egypt, it was not done. The third challenge we faced that we have to counsel the parents with this limited investigation. Only the mother is tested, the father refused to be tested, and there is no molecular test. So we counseled the parents that the father should be tested also, and we should do molecular testing for Tay-Sachs, which will be easier to do prenatal diagnosis when the mother is pregnant. And we offered the parents the reproductive option, which is at the time the only available was prenatal diagnosis. We didn't have PGD because, of course, that we didn't have molecular testing, and we didn't. It was not available in all centers. We stressed upon that the fact that Tay-Sachs does not explain the early death of the 3 children with neonatal convulsion, and further testing or further pregnancy outcome should be the child should be tested at least by extended metabolic screen, and this is mandatory. After 3 years, the family presented with another 3 weeks baby girl who had poor suckling and respiratory distress, and metabolic screen was not done as advised. Parents went to several other doctors, and they all reassured the parents there is nothing to fear of, and they only have to do prenatal diagnosis for Tay-Sachs by enzyme assay. This baby was delivered full term by cesarean section, and the parents confirmed that they did prenatal diagnosis at 9 weeks of pregnancy, CVS with enzyme assay, and revealed normal results. They didn't have this result. We did extended metabolic screen, and it revealed elevation of branched chain amino acid, suggestive and diagnostic of maple syrup urine disease. The baby was started treatment immediately and had almost normal physical and mental development till the age of 10 months, when she developed the loss of previously acquired milestones and generalized tonic-clonic convulsions. Her amino acid levels were within average all through, and she was compliant to dietary treatment. So we have to look for another disease. Although the prenatal diagnosis revealed the normal results, the fundus examination revealed the cherry red spot. And now the diagnosis was Tay-Sachs disease was suggested and was confirmed by enzyme assay. And now we have 2 autosomal recessive disease in the same patient. After proper diagnosis, we counseled the parents again that how to explain the patient have Tay-Sachs, although they did prenatal diagnosis. We counseled them that they did it very early with CFS sample for enzyme assay and not molecular, and maternal cell contamination could have been done, and we have to support the patient anyway and keep her in the MSU diet. The level of branched chain amino acids were always controlled, but her neurological status, of course, progressed, deteriorated till her death at the age of 2 years. So we conclude that the presence of 2 recessive diseases in the same patient is not rare. This is not the only patient that we see this situation. We have many patients with this consanguinity that they have 2 autosomal recessive diseases. This may complicate the clinical picture, and so it is recommended to trust your clinical sense, and reaching an accurate diagnosis is of utmost importance for proper genetic counseling and family planning. This was published like 5 years ago or 6 years ago. I thank Dr. Heba Salah, Dr. Radwa, Dr. Osama for cooperation in proper diagnosis of this case. And thank you.
Thank you, Professor Suraf, for this nice presentation. It would be a great pleasure to introduce our guest speaker, Professor Kevin Strauss. Professor Kevin Strauss is a medical director, Clinic for Special Children, Pittsburgh, Pennsylvania, USA. Actually, Professor Strauss had experience, and they have been managing a lot of patients with inborn errors of metabolism, especially MSD. It would be a great pleasure to hear from him about the management of MSD and update. Please, Dr. Strauss, you can start.
Thank you. Yes. Can everyone hear me okay?
Yes, doctor.
Okay, and you can see my slides. Good. Okay, well, thank you very much. I want to thank the conference organizers and my colleagues, my professional colleagues, who I really feel honored to be sharing this conference with, and I'm glad that I can hopefully contribute something to the education today. Also for the very kind and respectful comments about the work that we've done in Lancaster, Pennsylvania. And in particular, I want to thank Professor Al-Hasnan for his really lovely talk on the state of MSUD care in Saudi Arabia at King Faisal and the excellent work they're doing there. So I'm going to talk today about our experience in Pennsylvania taking care of a large number of classic maple syrup urine disease patients over the last 33 years. Our clinic was started in 1989. Since 1989, we have cared for more than 200 maple syrup urine disease patients, most of whom have classic mutations. The majority are from the Old Order Mennonite population, but not all of our patients are Mennonite, as I will talk about later. And I'm going to cover some of the basic concepts of pathophysiology and treatment and share our outcome data. For those of you who are interested in taking a further careful look at this information, as Professor Al-Hasnan had pointed out so kindly, all of the data that I'm going to share with you today is freely available online, primarily in the two articles that Professor Al-Hasnan referenced. One is in Molecular Genetics Metabolism in 2020. That is a comprehensive review paper that includes details about dietary management, acute management, as well as liver transplant. It is open access online, and then we have recently revised the Gene Reviews review article on the NIH NCBI online database. And so please feel free to reference those, and certainly email me or contact me if you have any questions about MSUD. I have nothing significant to disclose. I will be showing you data from a dietary formula manufactured by Nutricia Corporation, a division of Danone Corporation. I receive no personal compensation from either company. And I should also say that I will be showing you some photographs of patients today. All the photographs I'm showing you are being shown with the signed permission of those families, but I would ask you not to screenshot or reproduce any of these images publicly, please. So let's start and talk about the pathophysiology. Pathophysiology of MSUD is very complex. I'm not going to show the metabolic pathway here because I think that most of our listeners are quite familiar with the degradation pathway for branched chain amino acids. I want to look at a slightly larger view of the pathophysiology. So if we start here on the left side of this figure, essentially leucine, which is one of the circulating neurotoxins in maple syrup urine disease, originates from two sources, either dietary intact protein or cellular protein inside the body. Now, protein inside the body constitutes about 11% of body weight, and approximately 10% of human protein is leucine. So if you want to remember as a shorthand, your body is constituted approximately 1% by leucine. Approximately 1% of your total body weight is leucine. And that's a large reservoir of leucine that can be released into the circulation during catabolic states, as we'll talk about a little bit later. Leucine normally undergoes a transamination reaction. This is a freely reversible nitrogen swap where the nitrogen group from the leucine amino acid is added to alpha-ketogluteric acid, here shown as green diamonds, to form alpha-ketoisocaproic acid, the purple triangles, and forms glutamate. Typically, this reaction in normal healthy volunteers goes from left to right and can also reverse right to left, and is actually very important in humans in the formation of glutamate, particularly glutamate used as a neurotransmitter in the brain. When you block the branched chain ketoacyl dehydrogenase complex on the left in classic maple syrup urine disease, both leucine and its alpha keto acid derivative accumulate. They enter the brain through specific transporters. SLC7A5 is the large neutral amino acid transporter of the blood-brain barrier. SL16A1 is the monocarboxylate transporter, the same transporter that carries ketone bodies into the brain. And both leucine and alpha-ketoisocaproic acid exert a different forms of toxicity on the brain. So alpha-ketoisocaproic acid at high levels reverses the normal nitrogen flow of transamination reactions. It leads to an accumulation of alpha-ketoglutarate, which is converted to pyruvic acid and ultimately lactic acid, here shown on the right-hand side. And in the process, it depletes tissues of alanine, glutamate, glutamine, and GABA, here shown as the lighter font. And when you see patients who are acutely ill with maple syrup urine disease and measure their amino acids, in addition to seeing the elevations of leucine, you'll notice a severe depletion of glutamate and GABA, as well as alanine, and these can be detected by MR spectroscopy of the brain during an acute crisis, as can an elevation in the lactate peak. This is shown here. This is data from a paper published in 2003 looking at serial MR spectroscopy of the brain in a newborn baby who was in the midst of a metabolic crisis. Going from top to bottom, you can see that as the child's disease progressed and the encephalopathy progressed, the N-acetyl aspartate, here shown in green, a marker of mitochondrial function, decreases progressively, as the lactate peak, the double peak shown in red, increases. This is a sign of acute reversible mitochondrial poisoning in the brain. It is fully reversible, but is often associated with a quite severe encephalopathy, and in neonates often coma and respiratory arrest. The way in which leucine exerts toxicity in the brain is a bit more complicated, and is primarily appears to be a phenomenon of competition at the blood-brain barrier. So here's a cartoon of the blood-brain barrier from the view inside the blood vessel in the brain. And the amino acids, the large neutral amino acids, or what are called zwitterionic amino acids, all share a common transporter, SLC7A5. This used to be called the LAT1 transporter, or the large neutral amino acid transporter. It's the same transporter that's been studied heavily in PKU research. And it's a common transporter for 10 different amino acids, which compete with one another for a single binding site on this exchanger. The consequence of this is that if we look more closely at the blood-brain barrier here shown in this cartoon, with the blood compartment represented on the left and the brain represented on the right, we can see this group of 10 amino acids. Most of them are essential. 2 of them are important precursors for neurotransmitters. Tyrosine and tryptophan are the substrates for forming cerebral dopamine and serotonin, respectively. When leucine elevations are high, the elevated leucine essentially competes with and inhibits the cerebral uptake of all the other amino acid substrates. And so leucine essentially exerts a kind of amino acid malnutrition or amino acid deprivation on the brain. And it also depletes the brain of multiple neurotransmitters, dopamine and serotonin, as well as glutamate and GABA. Over the long term, the consequence of these disturbances, both for protein synthesis and neurotransmitter synthesis, is structural alterations in the cerebral cortex and throughout the brain, shown here with a Golgi stain. This is a classic neuropathology study published in 1992. Here you're seeing images on the left of cortical neurons, their branches and connections, their dendritic trees in a control neonatal cortex, infantile cortex, compared to an MSUD patient who died in crisis of similar age. And you can see there are fewer neurons. The neurons have less robust branching and make fewer connections. And we believe that these structural abnormalities ultimately correlate to spasticity, gait abnormalities, motor impairments, cognitive impairments in older MSUD individuals. This also partially explains why those same deficits, as Professor Al-Hasnan has pointed out, are not reversible after an intervention like liver transplant. So let me talk a little bit about the cohort we see at our clinic in Pennsylvania. We are a relatively small nonprofit medical clinic. We provide comprehensive molecular diagnostics and analytical testing on site. We also provide a 24-hour day, 7-day week hospital service for our MSUD patients. The paper published in 2020 includes a 30-year review of 184 MSUD patients. You can see that the majority are Mennonites, over 100 of them, with a classic 1312 T to A missense mutation that is associated with no residual enzyme activity. We also have a considerable number of non-Mennonite classic patients. Because we have so much experience with MSUD, we get consultations and referrals from all over the United States and actually all over the world. We've managed MSUD patients now from about 17 different countries around the world. We also see a few intermediate cases and 2 intermittent MSUD cases, shown in purple here. The intermittent cases are brother and sister that have a mutation, a mild mutation in the DBT gene. Most DBT mutations are intermediate severity. And I will say that in my clinical experience, I have never encountered a truly thiamine responsive patient. I personally question whether thiamine responsivity actually is a disease. Although it continues to be perpetuated in the literature, I've not observed a case in my clinical career. This is the breakdown of age and treatment for our cohort. You can see that out of the 184 or so patients reported here, we have good data on 165 of them. This is the breakdown. The patients currently treated with dietary therapy are shown on the left as blue circles. This is their age breakdown based on sort of arbitrary cutoffs at 6 years of age, early childhood, versus 18 years of age, adulthood. And then you can see on the right, the gray diamonds represent patients who have had a liver transplant for classic MSUD, and I'll talk about that a little bit later. But what I wanted you to see here is we really are managing patients of all ages and almost an equal number who have received liver transplant as compared to dietary therapy. So we're really able to look at these 2 treatment modalities over the lifespan and really compare the outcomes head to head. So this is a topic that is something important to everyone managing MSUD. The acute metabolic intoxication or metabolic encephalopathy is the most feared complication and the most potentially lethal complication of the disease. I will say, as a caveat to my remarks in this section, this is a very difficult topic to cover adequately in the span of a relatively short lecture. And in fact, I can only really speak to it at a very high level in terms of principles of care. As those of you who have managed metabolic intoxication in MSUD know, it is very complicated. It depends on a lot of clinical experience, and it also is very much influenced by local resources. So one of the comments that Professor Al-Hasnan made during his talk, and particularly in reference to hemodialysis, is that we don't use hemodialysis at our center. We've never used hemodialysis, but I recognize very clearly that is in part because we have a lot of resources at hand at our local hospital that don't force us to use hemodialysis. And in certain contexts, certain clinical contexts where those resources aren't available, hemodialysis can be an extremely effective and life-saving measure. So I don't have any problem with it in principle. I think it's very context dependent. And in fact, what hinders acute MSUD therapy in many settings is not a lack of knowledge or a lack of professional expertise, but a lack of the tools that you need to manage it properly. Almost like having expert carpenters who don't have hammers and nails. I think that's a very good analogy. I think a lot of very capable and dedicated physicians all over the world have trouble managing MSUD because they don't have the right resources. This is a Mennonite baby who was diagnosed at 7 days of age by newborn screening. This is the classic posturing we call epistotonic posturing. It is a form of dystonia, acute reversible dystonia. It probably correlates most closely to acute cerebral dopamine deficiency. And in fact, this acute posturing can be reversed acutely by high enteral tyrosine dosing to overcome transport competition and the impairment of dopamine synthesis. Reversing the epistotonus with tyrosine does not actually alter the level of consciousness and does not improve the encephalopathy. You can see this baby is in metabolic coma, requiring invasive ventilation because of respiratory arrest, and is being managed with multiple IVs. As we saw earlier, this is the most feared complication of maple syrup urine disease. During these acute encephalopathic episodes, we see critical cerebral edema here on the right-hand side, with effacement of the cerebral cortex, obliteration of the cerebral ventricles, and critical intracranial pressure. In newborn babies, they can tolerate quite a bit of cerebral edema because of the open sutures of the skull. This cerebral swelling is much more serious in children with a closed cranial vault after fusion of the cranial sutures, and actually is probably most critically dangerous between about the ages of 5 and age 25, when the brain size is at its maximum relative to the volume of the intracranial vault. During that period of your life, an expansion of brain volume by just 3 to 5%, which correlates to a drop in serum osmolarity of just 3 to 5%, is sufficient to cause brain herniation. The most common type of herniation we see in MSUD is uncal herniation, which is represented there by the arrow number 2, where the medial aspect of the temporal lobe, the uncus of the temporal lobe, actually shifts down through the tentorium and will crush the brainstem, causing respiratory arrest and posterior cerebral artery infarction. So you're all well aware that the major principle, the overriding the treatment of MSUD, as with hyperammonemic states and a number of organic acidemias, is to gain control over internal protein turnover. And as we'll talk about later, this is where dialysis has limitations on its own, because hemodialysis fundamentally does not gain control over this process. Dialysis can acutely remove toxins and does so very well, but it doesn't prevent the fact that you need to gain control over cell protein turnover to really have sustained and safe decrease of toxin levels in the blood. There are a number of factors that drive catabolism. You see in the top in the red box here, counter-regulatory hormones or stress hormones are a major drive to causing degradation of cell protein and an increase in leucine. This would be hormones like epinephrine, norepinephrine, and cortisol, as well as glucagon. But there are a number of other variables that signal stress to the body and will cause breakdown of endogenous protein. Things like energy deficiency, insufficient calories, insufficient essential amino acids, hypotension or shock, infections are a very strong drive on protein catabolism, things like wound fractures and physical trauma, and also pain, agitation, anxiety. These can all drive up protein catabolism. We use a number of things in the clinical setting to gain control over the anabolic process and shift toxin back into cellular protein. So in the green, probably the thing that we use the most is insulin. So at our center during an acute metabolic crisis, we use high dextrose infusion rates, typically in infants, dextrose infusion rates exceeding 10 milligrams per kilogram per minute, up to 12, and even sometimes as high as 14 milligrams per kilogram per minute, which is about 2 times the normal hepatic glucose production rate. And that requires us to give a continuous insulin drip. So a continuous insulin drip is a mainstay of acute metabolic management at our clinic. Of course, that requires very careful glucose monitoring at the bedside, but it's in a very effective way to inhibit protein catabolism and support protein anabolism. I think this is an underutilized treatment for maple syrup urine disease generally. It typically requires some experience from usually an intensive care provider or somebody who has experience treating conditions like diabetic ketoacidosis, but it can really be a very effective strategy for reversing catabolic states. We also use very high caloric infusions. We make sure our patient is hydrated, free of pain, and then we use very high infusion of branched chain amino acid free amino acids. So just to talk a little bit about the resources that we utilize in our hospital, if we have a patient who presents at any age with a metabolic crisis from MSUD, at our hospital, we've arranged to be able to manufacture on demand a total IV nutritional solution, MSUD TPN solution. We can have these solutions running within 1 to 2 hours from the time the patient arrives in the hospital. That's an enormous advantage that we have. This kind of service, as far as I know, is only available at 2 hospitals in the world, our hospital in Lancaster and a hospital in Pittsburgh where we do our transplants. Now, in the absence of TPN, it's important to recognize that dropping a nasogastric tube, particularly in infants and young children, and running a continuous concentrated branched chain amino acid free enteral formula can be a very effective strategy when combined with IV dextrose and lipid infusion. So in fact, we will often use that strategy, even though we have TPN available, we'll often use that strategy in newborns and young infants because it's safer. You have less concern for causing electrolyte disturbances and other problems. So any MSUD formula that is devoid of branched chain amino acids will do. You can concentrate that in newborns or infants to about 1 calorie or 1.2 calories per ml, or 30 to 40 calories per ounce. And if the child is encephalopathic, not able to feed spontaneously, that can be delivered at a continuous rate through a nasogastric tube. Or a nasojejunal tube. And this can be extremely effective, and I think, again, is often underutilized or overlooked in the treatment of acute MSUD. At our hospital, we also have the ability to provide intensive neurological support in a neuro ICU setting. This is a young man, 18 years old, with an acute encephalopathy. This is to remind you all that acute and severe encephalopathy can occur at any age, and in fact is often more dangerous in older patients because of the reduced tolerance for cerebral edema. This patient has an invasive intracranial monitor in. He's comatose, so we're monitoring intracranial pressure. We're running intravenous isoleucine and valine solutions. For hospitals that don't have isoleucine and valine solutions, again, liquid isoleucine and valine can be delivered enterally. We use very high delivery of isoleucine and valine during catabolic states. Isoleucine and valine and their keto acids are benign neurologically. Elevations of isoleucine and valine cause no obvious consequences for the patient, and they very effectively helped to drive down the leucine levels. There is, what we observe over time is there's generally a reciprocal relationship between the delivery of isoleucine and valine and leucine levels in the blood. And so you can use isoleucine and valine acutely in high doses, in infants as high as 100 to 120 milligrams per kilogram per day, to actually help to lower the leucine more rapidly. The other thing I want to mention here, Professor Al-Hasnan very astutely pointed out the importance of sodium management and osmolarity management. So like hyperammonemia and urea cycle disorders, very often when patients present in a metabolic crisis, if they die from cerebral edema, it's not the ammonia level or the leucine level that was the immediate cause of death. It was a change in serum osmolarity. So in these states, the brain can not tolerate a decrease in serum osmolarity. Each percentage change, each percentage lowering of serum osmolarity causes an equal percentage increase in brain swelling. And so we use osmotic agents, mannitol and particularly continuous hypertonic saline drips, to try to keep the osmolarity stable throughout the hospitalization. We don't want to make the patients hyperosmolar. We don't want their osmolarities to be higher than normal, but we want to keep them within the normal range and prevent them from decreasing. Again, these are therapies that are better instituted in an intensive care environment if your hospital can support that. And you can work very closely with intensive care providers in the care of MSUD patients. We're also able to do amino acid monitoring in our lab 24 hours a day, 365 days a year. So at our clinic, we have an on-call laboratory team. Just like we have doctors on call, our laboratory technicians are also on call, so that when we have a hospitalized MSUD patient, we can get amino acids done any time of the day or night, any day of the year. And this really helps to facilitate management. And again, is a real barrier to care in other settings, unfortunately. So this is the marker of sustained metabolic control. So what you see here is plasma leucine level during an acute metabolic crisis relative to the hours of treatment. On the x-axis, the gray bar at the bottom shows you the normal range and standard deviation for control leucine levels. So that's our target range. The red line shows you a typical course in an infant. So using the combination of therapies that I've now just presented to you, we can typically drive the plasma leucine down by between 1,000 and 1,300 micromoles per liter per 24 hours. A very rapid rate of drop, almost similar to what can be achieved with hemodialysis in infants. Applying those same therapies to adults, shown in blue here, you see that the rate of decrease generally is slower in an adult patient. And this probably has to do with the fact that protein turnover in general and anabolic capacity in general is slower in adults who have reached their normal growth rate and are no longer accreting intact protein and leucine. And so many people are under the assumption that MSUD is more dangerous in newborns and infants, and I would propose to you that actually MSUD, I believe, becomes more dangerous as patients get older, becomes harder to control, and has more long-term sequelae. I just want to show you this just to make the point, as I said earlier. I have no fundamental opposition to hemodialysis. Here we can see how effective it can be. In fact, this is a case that I was involved in back in my residency days over 20 years ago at Boston Children's Hospital. We managed a patient with acute MSUD crisis using hemodialysis in the ICU. That's shown here with the purple diamonds, and the red line On the left, the heavy red line shows the time during the hemodialysis run. So a very rapid drop in leucine levels over a period of just about 7 hours. And you can see in that time period, the leucine decreased from a very high level of almost 3,500 down to just around 1,000 micromoles per liter. Now, this is compared to what can be achieved in a patient with a similarly elevated level over 4,000, shown in blue circles, using just enteral treatment and TPN. The important thing to recognize here is, and the reason I put but there, is that if you use hemodialysis, you must do so simultaneously with an anabolic strategy. So you cannot do it instead of using some kind of anabolic strategy, such as enteral feeding with formula or TPN. You can do it in addition to, because if you do hemodialysis alone and you don't support protein anabolism afterwards, the levels go right back up again. They'll bounce right back up again. So I think that's a very important point to make, that hemodialysis can certainly cause an emergency rescue of a patient who's in severe crisis, but it has to be coupled with sustained protein anabolism afterwards. So let's talk a little bit about chronic metabolic control and the role of dietary therapy. Chronic metabolic control can be thought of in a few different terms. Primarily what we're interested in is this notion of leucine tolerance. Leucine tolerance is defined as the amount of leucine a patient can take in a day, defined in milligrams per kilogram per day, and still maintain a plasma leucine level within the normal physiologic range. You can see this drops precipitously with age, starting at an average of about 70 and decreasing to 10 to 15 milligrams per kilogram per day after about age 12 years. Notice that it actually roughly inversely follows the weight curve for infants, and that's because leucine tolerance is very closely correlated with the rate of weight gain. Remember that each 1% of increment in body weight is 1% of new leucine added to the lean body mass. And so that's what accounts for the high leucine tolerance in very rapidly growing infants. This provides some advantage for very young babies because it allows us to give them more intact protein when they're very young. But of course, once a person reaches their normal adult body size, the only leucine they can tolerate is the leucine that falls away from the body every day in the form of skin cells, hair cells, and feces. So what we call insensible protein loss. So just as we speak of insensible water loss through the skin, we can speak of insensible protein or leucine loss. In adults, that ends up being just about 15 to 25 milligrams per kilogram per day of leucine. You can see with classical patients, this is how this principle equates to dietary protein distribution. So here what we see is we're looking at over 13,000 individual values calculated from diets collected over 30 years, showing you the percent of intact protein on the bottom, shown as a regression line in red, versus the percent of branched chain amino acid free or formula protein up top in blue. The important point about this slide is, with very little exception, patients with classic MSUD never tolerate more than about 30% intact protein in their diet, and by late childhood, early adulthood, are really tolerating only about 15% of their total protein as intact or natural sources. So these patients are highly dependent on synthetic medical foods, and this is a major setback for quality of life. It's stigmatizing. The patients are aware. This makes them very aware that they're different from their peers. It makes them feel socially isolated. Many are embarrassed by it as they become older. And as we'll talk about later, this is is very important to consider when thinking about interventions like a liver transplant, because from the patient's quality of life perspective, this is one of the most onerous or difficult parts of the disease. Now, as with many metabolic disorders, we see over time a waning of metabolic control with advancing age. So this is a complicated graph, but this is mean and standard deviation values for plasma leucine, shown as blue circles here, relative to, and that's on the right-hand y-axis, relative to the amino acid samples drawn per year. So the average number of amino acids monitored per year, that's shown as the dashed line, purple diamonds, and it's shown on the left-hand y-axis as a function of age. The gray bar at the bottom is the normal range, control range for plasma leucine. So what you see is the leucine drifts up, the average leucine level drifts up with time. We see a very similar phenomenon along a similar timeline in PKU. And the frequency with which patients check amino acid levels decreases with time. Let's look at that a little bit more closely. So if we look at the annualized average leucine, so this is taking all leucine levels for a patient collected over a 1-year period and averaging them. And we compare that to the amino acid samples, the number of amino acid samples drawn in that year on the x-axis. We can see that when patients are collecting more than about 40 amino acid samples a year, 30 to 40 amino acid samples per year, collecting amino acid samples more frequently doesn't appear to really improve metabolic control. There's a very important principle in this slide, and one that is often surprising to clinicians. It means that really, to follow best practices with metabolic control, you really should be collecting an amino acid sample from your patient every 2 weeks. Now, I know this is difficult to achieve. I know that probably there are many listeners that are thinking, oh, Dr. Strauss, that's impossible. There's no way we can do that. I understand that. I understand there are real challenges to doing this. This is something that's relatively easy for us to do where we are in the United States. But I do think it's important to recognize that there is an evidence base here for suggesting that the frequency of amino acid monitoring is a very strong predictor of metabolic control overall. And so I would encourage you to work as best you can in your practices with your hospitals, with your local laboratory services, to improve the frequency of monitoring for your patients. It really makes a difference. So let's take a look at outcomes for the dietary cohort. In general, adapting these principles of dietary control, we've seen major decreases in hospitalization rates since the clinic started in 1989, when the hospitalization rate for MSUD patients averaged 7 hospital days per patient per year. We've decreased that rate by more than 97% to just about 0.2 or 0.3 hospital days per patient per year. Notice that in the last 41 patients treated prospectively at our center, 41% have never been hospitalized, never been hospitalized. So these are patients who were diagnosed as newborns from cord blood using rapid molecular high-resolution MELT testing for the Mennonite mutation. These babies were diagnosed at an average of 6 to 12 hours of life using this test, were managed in the perinatal period at home using MSUD formula, and have remained healthy in the outpatient setting. So this can be accomplished with the right local resources. We've seen normal body growth and, importantly, normal head growth. So we've had no patients treated since instituting these practices in around 2003. We've had no patients with microcephaly or any other or stunted growth. We have noticed that our MSUD patients treated prospectively have achieved normal motor milestones. So here we see sitting, crawling, walking, and climbing stairs. The MSUD patients treated prospectively represented with the light blue lines. These are what are called time to event curves. So it's a Kaplan-Meier type analysis. The gray dashed lines in the background are actually achievement of the same milestones by their siblings who don't have MSUD. So we're actually comparing within families. Each child is paired with a sibling without MSUD to really compare stringently their development. And we can see that all their early milestones are achieved normally. The long-term cognitive outcomes are less favorable. So if we look at the cohort born between 1967 and 2004, if we divide our larger cohort into two, I'm going to take a little time on this slide because it's complicated, but the message is important. So if we look at that older cohort, we've done Stanford-Binet IQ testing on a large number of those patients. And again, for each patient, we have recruited a healthy control sibling to compare them to correct for genetic background and family influence and so forth. On the left axis, the symbols represent the 8 domains of IQ testing. That's memory, visual spatial reasoning, quantitative reasoning, knowledge, fluid reasoning, verbal IQ, nonverbal IQ, and full-scale IQ. The x-axis depicts the mean and range of the percent deviation from control, where the central gray vertical dashed line at 0 would indicate that the MSUD patients do not differ from their non-MSUD control siblings, okay? So what you see here in this cohort of MSUD patients born between 1967 and 2004 is that in all domains of cognitive function, they are on average 40 to 50% below their siblings. These are pretty significant intellectual and cognitive deficits. If we look now to a group treated prospectively with the same metabolic formula, and according to the principles I've outlined here for you in this talk, this is a group born from 2005 up to 2018. They do fare better. Their IQ scores are 5 to 20% on average below their siblings. But the important point is that even under the best of circumstances, MSUD patients, many of them, can still be expected to have some cognitive impairments as they get older. This suggests that there are still significant unmet needs in this community and that certainly better treatments are needed. The other, I think, under-recognized problem in MSUD is the very high prevalence of mental health problems as patients get older. This, on the y-axis, is the probability of developing affective illness, including that definition includes depression, severe depression, anxiety, obsessive compulsive disorder, panic disorder, as a function of age. The gray line, the gray dotted line, horizontal line here, represents the normal lifetime incidence of these disorders in all populations. So approximately 20 to 21% of all people in all populations experience a major affective illness during their lifetime. And what we see here is that in the blue line shows that MSUD patients have nearly a 100% risk of developing some type of mental health problem by the time they reach 30 years of age. We've seen similar outcomes in other populations, such as the PKU population. This may be directly related to ongoing metabolic disturbances or structural abnormalities of the brain, or it may also be a reflection of the significant stress imposed by a chronic life-threatening disease like MSUD. Notice that the purple dashed line at the bottom is the risk of mental illness and particularly depression and anxiety in the sibling controls of MSUD patients. So their overall lifetime risk is about 2 times higher than normal. And this gives you some indication of the severe stress, or what we call the collateral damage to family members living in a household with an MSUD patient. Just the stress of chronic disease, the stress on parents, hospitalizations, the misery that this disease imposes causes a big psychological burden on not only the patient, but also the patient's loved ones and family members. So let me show you some outcomes for liver transplant. Liver transplant is not a perfect therapy, as we've heard. There are significant risks involved. It's substituting one set of problems for another. However, it is important to show you it is highly effective and is the closest thing we have to a cure at the present time. So our original discovery of transplant was accidental. It was in a patient with classic MSUD, a Mennonite patient, who in 1997 went into acute liver failure, irreversible acute liver failure, from a separate cause. She actually was taking an herbal supplement that was overly fortified with vitamin A, and she developed irreversible cirrhosis and liver failure from vitamin A toxicity. You can see in the gray shaded area that in the days preceding her liver transplant, her branched chain amino acids were very elevated and out of control. You can see the leucine there in blue reached levels of close to 2,000. She was transplanted out of necessity, not because we felt like it would necessarily treat her MSUD, but it actually greatly, immediately, and very effectively stabilized her branched chain amino acids. And she was very quickly able to be weaned to a normal, unrestricted diet. I will say that we were not the first to discover this. We discovered it for the first time in this patient, but then as we looked to the literature, we noticed that there had been a case reported previously, a patient in France who had a similar acute liver failure, was transplanted and corrected the MSUD afterwards. There was a case report published in '93. We've done now over 100 transplants. I think the number is up to 104 for classic MSUD. Out of 115 patients with the Mennonite variant, the probability of being transplanted reaches about 65% by age 37. In the other classical patients we manage at our practice, 57 other patients with classic MSUD, that level exceeds 70%. These are statistically not different from one another, but you can see that generally there's a march towards liver transplant with age. So this is a complicated slide, but a few things to point out. There are definitely complications of liver transplant, no question about it. About 27% of patients have delayed wound closure or can have complications with the wound closure. In 1 in 4 patients, a second exploratory laparotomy is required to revise the hepatic artery or deal with other complicated issues like small bowel obstruction or bleeding. Patients can have pulmonary complications, pleurocentesis, chest tube drainage, and acute rejection occurs in about 50% of patients. Those acute rejection episodes can be managed with immunosuppressive therapy. We've not had anybody who's had to be retransplanted as a consequence. We have seen post-transplant lymphoproliferative disease, a form of lymphoma, EBV-related lymphoma, in 3% of patients. Importantly, though, graft survival is 100%. So we've had no retransplants in this cohort. And patient survival is 99%. We had 1 death out of more than 100 cases. That death was a surgical complication. So it was actually a late surgical complication. It occurred as a retroperitoneal herniation of the bowel through a small suture incision that had opened up internally and caused an acute bowel obstruction. And so I think that it's important to counsel patients that liver transplant is relatively safe, but it is not without serious risks that need to be considered. I will say that in many settings, with good surgical services, with high quality surgeons and surgery centers, these statistics are, the survival statistics and morbidity statistics are often better than what can be achieved with dietary and inpatient acute management for MSUD. In many settings, patient survival for MSUD is much lower than 99% with diet. So from the transplant experience, we've been able to learn a lot about the most informative biomarkers. And what's interesting here is these same biomarkers are going to be used, I hope, in the future to guide things like gene therapy or mRNA nanoparticle therapy. These are therapies that are in development currently as we speak, and are being tested in animal models. And these will be the key biomarkers that we use. So liver transplant has sort of helped us define what the most informative biomarkers are going to be for all future studies. This is a little bit complicated, but what it's showing you from left to right is the gray squares are a control population of 52 healthy Mennonites. The blue circles is classic MSUD patients on diet, classic patients on dietary therapy. The purple triangles here, the third column, is patients with intermediate MSUD on diet. The red diamonds represent patients who have had a liver transplant. And going across, you see these four groups for leucine on the left, isoleucine in the middle, valine on the right. And what you can see is that the average values shown as the bars after liver transplant are not much different than the average values for dietary therapy or intermediate MSUD. The important point of this slide is what really changes after liver transplant is the volatility or the variability of the amino acids. They come into a much tighter range, and remember, this range is maintained on a completely unrestricted diet. So these patients are able to eat what they want, and they have been, in our case, 100% protected from metabolic crisis, which is also a very important outcome. Now, a more sophisticated biomarker is the ratio of branched chain amino acids with one another. So in classic patients, a characteristic metabolic feature of the disease is that the circulating plasma ratio of leucine to isoleucine or valine to leucine, expressed as a ratio, is highly erratic and unpredictable. So when we lose natural function and regulation of the branched chain ketoacyl dehydrogenase complex, we lose that stoichiometric regulation of the branch chains, which is usually held very tightly in a leucine to isoleucine to valine ratio of 2 to 1 to 4. So for the dietitians who are listening, I would encourage you to always be looking not just at plasma leucine levels, but looking at all three of the branch chains with the goal to maintain the isoleucine approximately half of the leucine value and the valine level at 2 to 3 times the leucine value. So why is that important? Well, maintaining those ratios is important because the integrity of those ratios is in large part responsible for normal flow of those amino acids into the brain. So it's possible and actually frequent in patients with MSUD that their leucine levels are in the normal range, but isoleucine and valine levels are too low relative to the leucine. And those patients can have cerebral isoleucine or valine deficiency. They can lead to microcephaly, cognitive impairment, spastic diplegia. These are really important nutritional deficiencies in the brain that are often elusive or missed. And so maintaining these ratios is important. Notice how after transplant, we really bring those ratios under tight control. And that's really a very important indicator of intact enzyme activity in the living body. A classic marker is alloisoleucine. This is what we call a pathognomonic metabolite. This is a metabolite that is, as far as we know, only produced by patients with MSUD. You can see the dramatic reduction in alloisoleucine after transplant. In fact, 71% of all post-transplant samples, the alloisoleucine is undetectable, and it's lower than 40 in all samples. But to return to this point, patients don't care about that stuff. I mean, I think that, Professor Al-Hasnan said it better than I can, I think. What patients care about is that they feel normal after transplant. They can eat what other kids eat. They can go to a birthday party and have cake and have some lamb. They feel like they can integrate with their peers and it's very powerful. That's very powerful. When we heard talking about tribes, you know, the food we eat is partly what defines our tribe. And when we can't eat those same foods, we feel set apart or stigmatized. And so patients mostly care about those sorts of changes in the quality of their life and the inclusiveness of their life as an outcome for transplant. Of course, what parents care most about is that it removes the fear and the stress of always feeling like your child may end up in the hospital in a coma with brain swelling. And parents, as we've heard previously, Mennonite parents will give the same kinds of reports. They feel like there was a cloud lifted. They feel like there was a sword hanging over them that's been lifted from their necks after the transplants. It really can be quite liberating for these families to go through this. I want to come back to this point just to show you data that, as we've heard earlier, we've observed no changes, specifically no improvements in neurocognitive outcomes post-transplant. So here we can see on the left a full-scale IQ scores with the normal range indicated in gray between 70 and 130. Normal or pre-transplant IQ scores, blue circles for classic MSUD patients. These same patients had repeat IQ testing between 1 and 5 years later, shown as red diamonds, and you can see essentially no change, no statistically meaningful change. The same is true of affective problems like depression, anxiety, OCD. These persist in patients after transplant. Problems like spastic diplegia or gait impairments persist after transplant. But as Professor Al-Hasnan mentioned, patients have no regression or decline after transplant. So at least we seem to stabilize any neurological deterioration with transplant. But this outcome data, interestingly, at least in our experience, has driven a trend among the Mennonites to start to transplant their children at younger and younger ages. So initially, when we started doing elective transplants in 2003, we did them mostly on adults and adolescent patients. Increasingly, we're referring children for transplant as early as 6 months or 1 year of age. And we've had a number of children recently transplanted at a very young age in early childhood. And so if your local hospitals and local resources allow for it and have the capability for transplanting young children, there is no reason to wait. There's no good clinical reason or indication to wait. If parents understand the risks and potential benefits, then we advocate for doing transplants as early as is practicable in your setting. We heard about domino transplant. This is an interesting case. This is a Mennonite woman on the right-hand side who has classic MSUD or had classic MSUD. And she actually gave her domino segment of her liver to a PKU patient. This is a young a classic PKU patient on the left who had a lot of trouble managing her disease, was intent on having healthy pregnancies, and really just because of morning sickness and nausea could not tolerate formulas, had a bad reaction to Palynziq, and so liver transplant represented a way for her to be able to stabilize her Phe level and go through normal pregnancy. And so her PKU was cured with an MSUD liver, which is fascinating. As far as we know, MSUD is the only indication where a metabolic disease can be placed into another individual without giving them the metabolic disease. And the reason for that is relatively simple once you understand it. And it's the fact that leucine oxidation and branch chain oxidation is distributed in organs throughout the body. The liver actually only constitutes about 10 to 15% of total branch chain oxidation on a whole body basis. Most branch chain oxidation occurs in muscle. A considerable amount also occurs in the brain and kidneys. And so if we transplant an MSUD liver into a healthy patient or a patient with another form of liver disease, they retain that oxidation capacity in these other organs. So with that, I just want to conclude. I want to thank my small but mighty team here at the Clinic for Special Children. I really am blessed with, I'm very blessed to be able to work with a remarkable and dedicated team of collaborators. Also a very dedicated team of surgeons at the University of Pittsburgh Medical Center. I've now been collaborating with them for almost 20 years. and of course the patients who are the ones who inspire us and encourage us to keep striving to improve the quality of their lives. So thank you very much for your attention.
Thank you, Dr. Strauss, for this comprehensive brainstorming talk. I have 2 or 3 questions in the chat.
Of course.
The first one is about growth hormone therapy. What is your experience in giving growth hormone either to chronic patients with short stature or in acute setting like or instead of insulin? What do you think?
That's a very good question. There's been some interest in growth hormone in the past. I will say that many years ago, we tried giving growth hormone injections to patients in the hospital as an alternative to insulin. It does not work nearly as well as insulin. So if you have the ability to give insulin, it's much more powerful anabolic agent and strongly preferred. Giving growth hormone to an acutely ill patient can increase protein anabolic rates a little bit, but not much. And it is associated with a risk for hypoglycemia. So patients have to be people have to be a little bit cautious about that. And also remember that one of the potential complications of growth hormone, one of the side effects of it can be increased intracranial hypertension. So in a patient with cerebral edema, that's a complication we want to avoid. So I personally do not recommend using growth hormone in the acute setting. I have not used it in patients in the chronic setting on dietary therapy unless I'm using it specifically for the indication of short stature, in which case it certainly can be used safely. In that setting, it doesn't really improve leucine tolerance unless it actually improves weight gain. So leucine tolerance is much more closely related to the rate of growth in grams per day. Remember, as 1% of that is as leucine added to the body mass, than to height. So if patients take growth hormone and they get tall and skinny, it's not going to improve leucine tolerance unless they add muscle mass. Does that answer the question?
Yes. Because the question was about giving growth hormone also in short stature, in patients with short stature.
Yeah. It's certainly no reason you can't do it, but it won't really make a big difference in their metabolic control.
Yes. Okay. The second question is about the intracranial or the edema, with the brain edema in the acute metabolic insult. Should we do CT scan for every patient in acute crisis? Because sometimes moving the patient to the radiology department will be risky. Should we do CT brain for every patient, or should we depend only on the branched chain amino acid level?
It's a very good question, and it's one that we still struggle with in some cases. In general, if your patient is encephalopathic, if their state of consciousness is altered, if they're sleepy, confused, hallucinating, you can assume they have cerebral edema and just treat them as if they have it. In that case, we don't do imaging because we just assume they've got cerebral edema. And doing imaging, it can delay proper therapy. It's associated with risks, as all of you know. It can be a cause of getting IV lines blocked or broken loose. So we do CT scans very seldom. The only time we do them is if we have a patient who is in a deep coma and we're contemplating doing invasive intracranial pressure monitoring. So if we have a patient where we are considering putting in an intracranial pressure monitor or a spinal fluid drain, a cerebrospinal fluid drain, then we'll do CT scans. But generally, I don't recommend it for routine care.
Actually, do it in patients in our hospital because we thought if the patient levels didn't decrease rapidly enough, or there is a hypoosmolarity. It can appear in the CT, but we are not all convinced by this.
Yeah, I understand. I mean, my general point of CT scan and MSUD is, as with all tests, before you do it, make sure you know what you'll do with the result. Like, what will you do differently based on the result? So if I see a patient with MSUD who's encephalopathic and I do a CT scan, and the CT scan doesn't show critical brain edema, it doesn't change how I manage the patient. I still manage the osmolarity the same way. I still manage the patient as if they can develop a brain herniation. So I would say 100% of the time, you should be managing serum sodium and osmolarity as if they can have a brain herniation. If there's important information you can get from a CT scan that will change your management in some way, then of course it's reasonable to do it. But generally, I think it doesn't typically change my approach to the patient very often. Does that make sense?
Yes, of course. A third question is about that we had a few days ago a patient with a level of above 3,000 leucine, isoleucine level was above 3,000, and he was not in coma. She was not in coma. There is no CNS manifestation at all. There was a debate: should we go for dialysis or should we go for only dietary management? And because we are originally clinicians, we thought if there is no clinical manifestation, we should wait for the levels to decrease by diet, and it actually did. And the patient went home for 3 or 4 days after this, only on formula, without dialysis. But was this a right decision to do, or we should always start with if the levels is so high like this, we should start with dialysis?
No, in fact, I think that was the right decision. As I said, we've managed acute crisis for more than 30 years. I've managed now well over 300 acute metabolic crises. We've seen levels as high as 3,000, as high as 4,000. I think the highest level we ever managed was about 4,200. And in every single case, we've gotten them down with dietary therapy, with metabolic therapy, without using dialysis. So the dialysis case that I showed you was actually a case where I was a resident. It was during my training years. I was working with another metabolic physician. I personally, in my own practice, have never used it. I think that dialysis, the role for dialysis is really, I think there's two indications for using it. I think if you're trying metabolic therapy and it's not working, so if you're trying formula, dextrose infusion, insulin infusion, and that's not working for whatever reason, then dialysis is something you can do to rescue that patient, at least temporarily. I also think there are certain settings where dialysis is the only treatment available. There's some places where they can't even get formula, and they don't have metabolic trained physicians. And in those cases, dialysis is all they have. So I think in those settings, it's okay. But I think in your case, I think you absolutely did the right thing. Dialysis is risky, as you know. If you don't need to introduce the risk, then why do it?
Especially that we don't have hemodialysis, we only have peritoneal dialysis.
Right. And that's much worse. So as Professor Al-Hasnan pointed out correctly, peritoneal dialysis is actually not very effective for MSUD. Hemodialysis is the standard if you're going to use it at all.
The last question is about the liver transplantation. Dr. Nada is asking how MSUD patients benefit from liver transplantation if it is only responsible for 15% of leucine metabolism.
It's a great question. And all I can say is it's an empirical observation, meaning that what the transplant experience shows us is that that's all you need. 10 to 15%. So most of our enzyme systems in the body, most of our metabolic systems in intermediate metabolism do have about a 10-fold excess capacity. So we are built by our creator with more enzyme activity than we actually need. And if you think about your intermediate patients with intermediate PKU or intermediate MSUD, most of them have enzyme activity levels measured in fibroblasts on the order of 3 to 8%, 3 to 7%. So that's kind of your intermediate range. Once you get over 10% for almost any enzyme system, that's sufficient to function normally. So it's a great question, but in a way, this just proves how much excess enzyme activity most of us have.
Okay. Another question is about the lack of resources in our hospital in Egypt. We don't have amino acids level at all. We always use tandem mass spectrometry for following up the patients. So the tandem mass doesn't differentiate between the level of leucine and isoleucine, they put it together. And we try to calculate the level of leucine in relation to phenylalanine and so on. If this can...
All I can tell you, I mean, all I can tell you is I'm sorry. That's a very tough problem. It's actually, people ask me this very often. I get this question very often because tandem mass spec is the standard in many settings. It's really not appropriate for long-term management of MSUD. That's all there is to say about it. You really need to be able to separate leucine and isoleucine to do it properly, because in MSUD, leucine and isoleucine often are very much out of sync or out of proportion with one another. So it's quite possible that if you see a patient on tandem mass spec who has a combined leucine isoleucine peak of 2000, that what you're measuring is 200 leucine and 800 isoleucine,
Yes.
and vice versa. And that's a big problem because you don't want to admit the patient to the hospital. And so when you speak of your patient with a leucine level of 3000 who didn't need hemodialysis, that could have been isoleucine. That might be the reason why that patient was asymptomatic. I don't actually believe that the leucine was 3000 or the patient would have had symptoms. I think most of that was isoleucine.
Yes.
So I think you just need to advocate for your patients and do your very best to work with your hospitals and your laboratory systems to get HPLC capability. The fact of the matter is HPLC, which is used to separate all three metabolites and can detect alloisoleucine, is a lot cheaper and easier to run than tandem mass. It's just that our newborn screening, HPLC is a very simple technology. The machines are very inexpensive. You can buy them on eBay or Amazon. And, you know, from a technical point of view, the assays are simple and cheap. So it's just a matter of willpower and a matter of commitment. It's not a technological barrier. Does that make sense?
Yes.
Any laboratory that can measure a sodium level can measure amino acids by HPLC.
Okay. Okay, thank you.
Yeah.
Thank you again, Dr. Strauss. Now we'll move to our next speaker, my dear friend and colleague for the last 25 years, Dr. Ola Kharifa, Professor of Medical Genetics at Shams University. The floor of yours, Dr. Ola.
Thank you, Professor Salaf, for your introduction. Actually, it's a great pleasure for me Bismillah ar-Rahman ar-Rahim. Actually, it's a great pleasure for me today to share the 42nd International Ain Shams University Congress with the second International Conference on Inborn Errors of Metabolism on an MSUD. Actually, as the Professor Hasnan said and Professor Strauss, we do have in our medical genetic department at Ain Shams University in the metabolic clinic, we do have a large number of inborn errors of metabolism cases by which MSUD is a great burden. Also, it compromises around 1/4 of non-PQ patients. And actually, I wanted to share today about our not experience, but about just some. We found a great phenotypic genotypic correlation in our cohorts of patients. Maple syrup urine disease is a rare autosomal recessive inherited disorder due to the fact in branched chain alpha keto acid dehydrogenase complex, as have been mentioned before. MECD varies in severity and its clinical spectrum is quite broad, ranging from mild to severe phenotypes. MECD is predominantly caused by mutations in the BCKDH alpha, beta, as well as DBT genes. Considering the three genes determining the disease, more than 300 variants have been described according to the human gene mutation database today. Since there is no common variants, the molecular approach usually involves direct gene sequencing. In this study, we hypothesized the Egyptian population has a characteristic genotypic profile, which provided the base of our objectives. Actually, our objectives is to recruit a large cohort of MECD patients for molecular genetic variant profiling and genotype-phenotype correlation. 33 patients from related families were suspected for MECD based on clinical and the characteristic biochemical findings, including tandem mass spectrometry. MECD diagnosis was confirmed by molecular genetic analysis. All the enrolled patients were registered and followed up, as I've mentioned, at the metabolic clinic of the genetic department at Ain Shams University, Cairo, Egypt. To compare the degree of morbidity between individual families, we classified the examined families into acute neonatal or chronic intermittent type, as has been by Professor Al-Hasnan, and also for those with acute neonatal presentations, those patients has been differentiated according to the age of presentation, the neurological management, as well as if there is any history of other sibling deaths or just to review the phenotype of previous affected SIBs or relatives in the family. This can give a good clue to identify those patients accordingly, either acute neonatal forms or chronic intermittent types. The severity of the clinical presentation of MECD was assessed independently by two experienced physicians who have been caring for patients with MECD for more than 5 years. They reviewed the data of the patients and ranked them on a scale of 3, mild, moderate, and severe phenotypes. Clinical characterization of MECD by chemical testing for amino acid profile with tandem mass spectrometry. As we said before, we don't have an amino acid analysis, so we use tandem mass spectrometry and molecular confirmation by PCR amplification and single sequencing of the 3 causative genes. Prediction of variant pathogenicity by molecular modeling and several in silico tools, including SAFT, Bolofin-2 Condel, and was proven for the missense mutation. And we used also 6 other tools were used for the prediction of the conservation of the management side sites for those variant. Genotype phenotype correlation for this patient in our cohort of patients, we found the result that in a patient with MECD, 20 males, that 61% were, and 13 females, 39% of 32 families were clinically and biochemically diagnosed and subjected to confirmation by molecular genetic analysis. We found that consanguinity was noted in 28 families. As we know, there is a high degree of consanguinity, 88%. The median age of initial symptoms was 4 days. The classic phenotype was the predominant one in our cohort, 32 patients, 97%, and only we do have 1 patient has an intermediate form. Among the 32 families, we identify 17 pathological variants in 33 patients across the 3 genes that cause the disease, namely, as I said, BCKD alpha, beta, as well as DBT. 8 of the variants have been previously reported in patients with MECD. The remaining 9 variants were novel, as they have not been reported in HGMD, ClinVar, and VarSam database. These 9 variants were rare, as they were not seen in 200 ethnically matched normal control samples or found in 1,000 Genome Project EXAC or in Genome ID database. 12 variants were identified as frame shift and nonsense variants, which was the majority of the variants identified. 5 of those variants have been reported before in patients with classic MECD. The remaining 7 variants were novel and were automatically predicted as disease-causing, as they ultimately led to nonsense-mediated messenger RNA decay. 5 missense variants were also encountered in our study. including 2 novel and 3 previously reported variants. Variants of the BCKD alpha gene were encountered in 8 patients, whereas variants of BCKD beta gene were encountered in 14 patients, and DBT gene were encountered in 11 patients. The clinical severity of variant phenotype was well correlated with the genotype. As we can see here, those are the list of genes for branched chain keto acid dehydrogenase complex of MCD patients in our cohort. As I'm showing those the novel variants which had been identified for our cohort of patients. And as we can see here, for the first BCKD alpha gene variant were encountered in 8 patients. 3 patients as we can see, patient 1, patient 2, patient 3 had novel deletions leading to frame shift and the premature stop codon. And this type of mutation was correlated with a severe phenotype of those patients. As we can see also, there is here we can see there is a missense mutation, which I'll mention in a few seconds about what we did for the structural modeling and the rank scores to define that this variant were found to be correlating well with phenotype. And we also identified, as I said, 4 other previously reported variant have been described, homozygous missense variant, and patient 8 had a previously reported nonsense variant. For the BCKD beta gene variant, as we can see that there are 14 patients. 2 novel missense variants were detected in 4 patients, as we can see here. And also previously reported nonsense variants were found in 3 patients, and 2 other previously reported missense variants were found in patient 13 and 18. Whereas there is 2 novel frame shift variant were found in 2 sets of unrelated patients, patient 19 and 18, as well as patient 20 and 21. And interestingly, that those patients, they are not related and they do have the same variant. And again, those variants was correlating well with the phenotype of those patients. We found for the variant which was identified in DBT gene, as Professor Strauss said, that most of those variants we found moderate phenotype or mild phenotype of the variant, and all these variants are nonsense variant in the DBT gene. For the pathogenicity of the missense variant, as had been mentioned for also the patient for MCD patients for Professor Strauss, we do have this for this mutation 1312, as I've mentioned, that this mutation was identified to cause a severe phenotype, which had been identified in 4 patients. And we did structural modeling, as we can see here. There is a wild form, and here there is a missense variant. We can see the variant as per gene in red was different in size and the charge from the wild tyrosine residue in green. This led to failure of formation of the natural hydrogen bond. The resulting molecule was less hydrophobic than the wild polypeptide chain. And also this was going with, as I said, for the phenotype of our patients, and also for the average rank score, it was the highest rank scores for all the missense variants which had been identified for those patients. For the BCKD beta, we found the first missense variant was novel and was encountered in patient 9 to 12, and the variant position was well conserved on the surface of the molecule. It was predicted to be disease-causing by all in silico tools with high average rank score, and the genotype was largely, again, consistent with the moderate phenotype of affected patients. The second missense variant of the BCKD beta gene had been been previously reported and was encountered in the only Yemeni patient. As I've said, the cohort of patients, we do have all patients with the classical phenotypes except one patient with the intermediate phenotype for this Yemeni patient. And this was the only patient who presented with an intermediate form of the disease. Actually, this patient was well, and he presented around the age of 5 months with just a moderate crisis, and he was not having anything before. And in silico study showed that the variant had the lowest pathogenicity score among the studied variant, and it involves a non-conserved residue. The mild clinical presentation of the patient was consistent with that predicted by in silico study. Whereas the third missense variant, beta gene was novel and was encountered in one patient. Again, in silico tool predicted that the variant is classified as disease-causing and expected to be deleterious to the function of the molecule, with a high average rank score of the tools for the prediction of pathogenicity. The moderate phenotype is consistent with the predicted by the in silico tool, where the average rank score of pathogenicity was in the middle of the table among the studied missense variant. Whereas the fourth missense variant was previously reported and was encountered in patient, multiple in silico tools also predicted that this variant had a deleterious effect with a high average rank score of predicted pathogenicity. In silico analysis of this genotype adequately predicted the severe phenotype. As we can see here in this figure, those are the presentations for the missense variant. For the D3, 4D variant, A1 and A2, interatomic interactions, for A3 and 4 changes in the hydrophobicity, for 5 and 6 changes in the surface charge. And for the second variant, again, we can see clashes between invariant leucine residue and the surrounding NC blue. And we can see also for the other type of variant. So this one for BCKD beta variant, and this is those for the second, this is for the third, and this is for the fourth. And we can highly see how those variants, as we can do molecular modeling to show how those correlates with the phenotype we observe it in our cohort of patients. Actually, when we do have a patient having a severe phenotype, those patients do have a lengthy stay in PICU. Those patients had initial diagnosis. As I said, the average age of diagnosis is 4 days. And those patients, we do have increasing leucine level more than 1,600 micromole per liter. And those patients necessitating to be intubated and to have lengthy stay in neonatal intensive care unit. As I have mentioned, those are the average rank score for the missense variants, which can show the ranking score for the variants, which augment what have been done by the molecular modeling for our patients. In conclusion, this study emphasizes the importance of identifying the genotype of patients with MSUD. It shows that extensive in silico modeling studies may give a clue to the pathogenicity of the variant and the prediction of the prognosis of individual cases, especially in patients with a missense variant, where the average rank score for several in silico tool correlates well with the severity of the disease. Pre-implantation testing is highly recommended for consanguineous couples at risk for having affected offspring with MSUD, and this helps for the implementation, as have been said by Professor Hasnan and Professor Strauss, very important. We have two strands on prevention. The implementation of newborn screening program by tandem mass spectrometry plays a substantial role in early diagnosis and identification of asymptomatic neonates with MSUD. Molecular testing for detection of MSUD variant gives a reasonable approach for pre-implantation genetic diagnosis for at-risk families. Actually, for our study, there is one thing which to us is lacking, as has been said before, quantitative amino acids. This was very important to monitor our patients, but we monitor our patients regularly by tandem mass spectrometry. Thank you.
Thank you, Dr. Ola, for this nice presentation. If we have time, I think, for the question in the Q&A box. Dr. Sahar is asking if MSUD is diagnosed early with newborn screening approach. This might be possible to establish genotype-phenotype correlation more efficiently.
Actually, as I've said, for genotype-phenotype correlation, we studied only not that large or large group of patients but what we found in our patient for those genotype-phenotype, I can say for newborn screening, as I've said, there is no specific type of mutation we can do for those patients. So I think it's hardly we can predict early. I wish that we can have much more center studies for more patients so we can get a common mutation. It could help it to be done for the patients for early detection and helping those patients from the start.
Thank you again, Dr. Ola. Dr. Muhammad is asking, how can we classify classical, intermittent, and based only on genotype?
Actually, as I said, for our cohort of patients, mainly a classification for the patients is based upon the clinical, for the age of diagnosis, for the presence or absence of neurological symptoms. And I wish that MSUD in Egypt have also more genotype to be present, so we can say there is a certain type of mutations with mild phenotype or others not. Actually, what we did or what we saw in our study that we can, for them, especially for the missense mutation, we can see that there is some type of mutations, severe mutations. They do have a severe phenotype. Actually, it could help for using genotype-phenotype correlation for MSUD patient. For that came idea for our study. I think I just encourage all centers to do structural molecular modeling and to do in silico analysis, just to pick more phenotype, more genotype, especially if there is a novel mutations.
Okay, there is another question. How much pre-implantation diagnosis costs?
I can leave this question to Professor Sraif. I think she deals a lot with such patients in Egypt.
Okay.
The cost?
Okay, the cost, of course, Dr. Faida, you have to know the mutation. You can't do PGD without knowing the mutation. So you have to test the patient first for mutation. And then the PGD in Egypt costs nearly 90 to 100,000 pounds. Okay. Thank you again, Dr. Ola. And now to our third guest speaker, Dr. Iman Mohammed Mujahid. She's a senior metabolic dietitian specialized in dietary treatment of inherited metabolic disorders at King Faisal Specialized Hospital in Riyadh, Saudi Arabia. She has been a speaker in several national and international events. She also has been a member in several metabolic workshops and awareness days. She developed several instructional materials and booklets for patients with inherited metabolic disorders. She participated in quality improvement activities, protocols, and clinical research, and has 3 publications as a co-author. Her presentation will be about the dietary management of MSUD. Go ahead, Dr. Iman.
السلام عليكم ورحمة الله وبركاته. Can you hear me? Is my voice clear? Is my voice clear?
Clear, Dr. Iman.
Dr. Sula.
Yes, the voice is clear.
Okay. First of all, I would like to thank the organizing committee at Ain Shams University, especially Dr. Ola and Dr. Sula, for giving me this opportunity today to be part of this event. Today, I'm gonna talk about the dietary management of MSUD, and it actually makes my job hard to present after these wonderful speakers here from me today. Of course, I won't go through the clinical or the pathway, the chemical pathway of hospital at King Faisal Hospital. We are following about 81 patients who are affected with classical MSUD in metabolic nutrition clinics. Is of course the restriction of these toxic branched amino acids, which are leucine, isoleucine, and valine, and at the same time to prevent them from being deficient. Maintaining a normal growth and nutritional status is one of the goals. Avoiding catabolism, especially during illness, is an important part in the dietary management of these amino acid within a target treatment range, which is not associated with the neurotoxicity, especially for leucine, is also a critical part in the dietary management of these patients. And of course, meticulous treatment during illness or during emergency to prevent catabolism and metabolic decompensation is also important. How can we achieve this? Of course, by restricting the protein intake of these patients, we can restrict consequently the leucine, isoleucine, and valine intake. And this is, of course, would necessitate following a very tough diet, which prevent these patients from eating any high protein containing food, including meat, fish, cheese, nuts, seeds. All of these are unfortunately unallowed to be. General principles in the management or in the dietary management of these patients. First of all, we have to restrict the intake of leucine by restricting the foods that contain high amount of leucine, and of course we will provide the patient of the allowed amount of leucine in milligrams or the allowed amount of protein in grams. In order to make sure that these patients are growing well and getting enough protein for normal growth, we have to provide them with the rest of amino acids in a form of a special amino acid-based formula. Of course, we have to make sure that they are taking enough energy and calories at all of the nutrients, either macro or micronutrients needed for these patients, especially when we are talking about essential fatty acids, vitamins and minerals. Also trying to make the tough diet palatable infant with an MSUD, how much calories, lipids, protein, what are the
Dr. Iman is disconnected.
اوكي نستنى كده ثواني. I thought I have the connection problem, not here.
sorry, Dr. Sulaf.
Okay.
Hello.
Hello.
Hi. Hello.
Hello, Dr.
Hello?
Iman. We are hearing
Yes,
you.
can you hear me now? Yes, okay.
Yes.
Sorry, I think I lost the connection for the last 2 minutes.
Yes. But now you are.
Yes, okay. So let's go to the previous slide, or this slide. This is the slide that
Can you please share your screen again? Because your slides doesn't appear.
I will share again. I will share my screen again. Does it appear now?
Yes, yes. Can.
Okay. Is this one the slide that before I lost I lost the connection?
Yes, yes, this slide.
Was it this slide? Yes. Okay. Sorry for this technical issue. As I have mentioned before, there are general principles in the dietary management of MSUD, which consist of a calculated amount of leucine, calculated amount of special making sure that these patients are getting enough and micronutrients, including minerals, all of the time, and making sure that these patients are taking enough energy and calories all of the time is very essential and mandatory when treating these patients, especially during crisis. This table shows the calories, lipids, protein, and leucine that should be provided for these patients, whether they are asymptomatic infant or they already in crisis. As you can notice here, that the plasma levels of these patients should be kept between 100 to 300 micromole per liter for leucine, and between 200 to 400 micromole per liter for valine and isoleucine. What are the suggested branched chain amino acid levels that are recommended while treating these patients? Actually, we are following at our institute the guidelines that were set by the GMDI consensus in 2013 that says that leucine level should be kept below 200 micromole per liter for patients who are below 5 years of age, and not to exceed 300 micromole per liter for patients above 5 years of age. And we are trying our best to maintain isoleucine and valine levels between 200 to 400 micromole per liter. How much protein do these patients need? Actually, all of them will require higher protein intake because most of the special amino acid based formula, and it is well known that the absorption of amino acids is less effective than intact protein. That's why we have to provide them with higher protein intake, mainly from the special formula. And there are so many companies that have different kinds of these special formulas. They come as a powder form during infancy, a gel form afterwards, and it can be given as a liquid form in adulthood. These formulas contain all of the amino acids needed, plus carbohydrates, fat, minerals, and fats needed by these patients that will meet their recommended daily intake for all nutrients. The valine and isoleucine supplementation for these patients is very crucial and Dr. Strauss has emphasized on the importance of keeping isoleucine and valine within the treatment range. So always make sure that you are supplementing your MSUD patients, especially during infancy, with adequate amount of isoleucine and valine that will ensure that your leucine level will be kept within the normal range. How this valine and isoleucine supplementation could be given. They are usually coming as in powder form or a ready sachet that is combined with added carbohydrate. In our institute, for example, they are prepared by the pharmacy as a prescribed medication. It is preferably that they are added to the whole amount, the whole 24-hour amount of MSUD formula, and or if you will give it as a single doses, it's preferably that they are divided into at least 3 doses, making sure that the patient will take these 3 bottles completely. It's very important for metabolic dietitian to keep an eye on any signs or symptoms of branched-chain amino acid deficiency. For leucine deficiency, a low appetite, apathy, irritability, low weight gain can be a sign or a symptom of low leucine level. For isoleucine deficiency, and maybe some of you have seen it in infants with MSUD that were mistreated, which is the acrodermatitis enteropathica-like rashes. These are severe rashes that might be seen in patients who would have a severe isoleucine deficiency. For valine deficiencies, these patients might experience poor appetite, excess irritability, and crying as well. Here is a picture of one of our patients that has been referred to us or transferred to us from a local hospital, and unfortunately, she was kept by the physician and the dietitian there on 0 branched chain amino acid MSUD formula for more than 1 week, which has resulted in these severe skin rashes and acrodermatitis. Okay, how much leucine does this patient tolerate? As Dr. Professor Strauss mentioned in his presentation, the leucine tolerance differs from one patient to another depending on the age, phenotype, the enzyme activity. But of course, most of the classical MSUD patients won't tolerate that much leucine. And to know how much leucine these patients would to add leucine gradually from infancy and monitor the labs closely. Here is a table that shows the recommended daily intake for protein, branched chain, amino acid, and energy intake for MSUD patients. You can notice here in the energy column that these patients need higher energy intakes when compared to their healthy siblings. That increased with age. Once they get older, they start to count grams of protein rather than milligrams of leucine because it's more convenient to them. And you can notice here that after the age of 40 years, they might not tolerate more than 8 grams of protein per day. So, as I have mentioned before, divided by the grams of protein that are allowed daily, the first 6 months of age, as it is easy to know the leucine content of infant formula and give them a list of protein content for the food in order to not to exceed it. Actually, Faisal Specialist Hospital, we are following the 60 milligram leucine exchange, which equals to about 1 gram of protein. And here is an example of how much 60 milligram of leucine equals. It's very minimum. For example, only 15 milliliter of cow's milk equals to 1 gram of protein or 60 milligram of leucine. So you can imagine how difficult the diet of such patients can be. We are allowing fruits and vegetables in any amount as long as they are bare 100 vegetables are allowed for these patients, except of course for starchy vegetables. They have to come then. There are few food items that are allowed freely for these patients, and of course these foods would be the zero protein containing food like pure fats, pure sugars, and of course the special protein food that are manufactured by special companies, and they contain less than 0.5 gram of protein per 100 gram of the item. And of course energy supplements that contain zero protein are also most of the time incorporated in the diet of these patients in order to increase their caloric intake. You have to make sure as a metabolic dietitian that these patients are meeting the APA and the DHA, and most of the time of these, if these patients are taking the calculated all of the prescribed amount dietitian, you will make sure that they are taking the required amount of all of the nutrients, including essential fatty acids, because these formulas always are enriched with all of the nutrients needed. as I have mentioned before, the energy intake of these patients is very important. You have to make sure that these patients are taking enough calories, at least meeting their recommended daily intake during stable days and exceeding up to 20% of their needs during a crisis in order to prevent catabolism. How can we monitor these patients as metabolic dietitians? There are diagnostic, of course, specific labs, which are the quantitative amino acids. And also there are comprehensive nutritional labs that are done every year or every 6 months or as needed, such as hemoglobin, hematocrit, vitamin B12, ferritin, iron, zinc, selenium, and of course also pre-albumin. This is of course done during the clinic visits, which are usually every 3 months during the first year of life, every 6 months after the age of 12, and yearly in adulthood. And there is an interesting table that shows suggested frequency of monitoring that can be found in the GMDI website, and I would advise you to go through all of the guidelines that are published there. Actually, unfortunately, also, as you mentioned, in Egypt, we have the same problem in our hospital. We mainly depend on tandem MS for monitoring our patients, which is not a reliable method, but because most of our patients are outside Riyadh, so they have to send it by mail, and that's why we are depending on tandem MS for monitoring our patients. But whenever they come to Riyadh or come to visit us, we order the quantitative amino acid during the first year of life, and adjusting the formula according to the levels should be done immediately. With the parents and to adjust the formula according to the branched-chain amino acid levels. But sometimes we have a high leucine level without any obvious taking enough formula. Is this big?
Dr. Iman is disconnected again. Dr. Iman, you are disconnected.
Okay. Can you hear me now?
Yes. Can you please share again your slides?
Sure. Sorry again. Okay. Was it this slide? Yes. Before I got disconnected? Yes. Okay. So I was saying that whenever you have a high leucine level without an obvious illness or infection, you have to ask yourself if this patient is taking enough calories, is he taking enough formula. Evaluate also the isoleucine and valine intake of this patient. As Dr. Strauss mentioned about the ratios, you have to make sure that the ratios between isoleucine and between leucine, isoleucine, and leucine and valine are always correct. If you have ruled out all of these causes, you can go back to the amount of leucine allowed of this patient and decrease it if you think that this is the cause. Dr. Strauss also mentioned that the patient during accelerated growth might need more leucine, but after this, during late adolescence, for example, or during late infancy, this higher leucine intake might need to be revised and adjusted. For the newly diagnosed patient, how can we manage them as a metabolic dietitian? In our institution, sometimes we would go for hemodialysis if the levels are highly elevated. But the most important thing is to start enteral feeding or nutritional therapy as soon as possible. If patient is able to take orally in an enough amount, so please start home in a zero-branched amino acid formula. Then after 24 hours, you have to start to supplement the patient with isoleucine and valine at a minimum of 50 milligram of each, even if you don't have results ready. And make sure that you will provide him with higher energy intake up to 120 kilocalorie per kg. Once the levels of leucine are below 800 or 700 micromole per liter, you have to start to reintroduce leucine at the minimum by 20 milligram per kg, then increase it gradually as tolerated based on labs. And during this time, you have to adjust the valine and isoleucine supplementation because, as you know, that the standard formula or the breast milk that contains leucine, it contains, of course, isoleucine and valine at the same time. So you have to adjust the supplements accordingly. Is breastfeeding allowed in patients who are affected with MSUD? Yes, actually, mothers who are having children affected with MSUD can breastfeed their children or at least express the milk until the patient is stable, and a very close monitoring of patients who are allowed to be breastfed is required. Here is just a flow sheet of how to manage patients who are newly diagnosed with the MSUD as a dietitian. Again and again, it's the same process. You have to provide them with zero-branched amino acid formula orally or through NGT as continuous feed. If NGT feeds are not possible or the patient is having any gastro issue, you can insert an NG tube. Unfortunately, in our hospital, we don't have the privilege of the custom TPN as in the United States, neither, of course, the intravenous isoleucine and valine supplementation. So we are mainly dependent on the nutritional management of these patients. So make sure that they are taking also enough isoleucine and valine supplementation, enough protein up to 3 grams per kg for these patients should be provided with enough calories up to 120 kilocalorie per kg. This protocol was done by our hospital, and I think Dr. Hasnan has gone through it. This is the protocol that we utilize whenever we have a patient who is at risk or a neonate who is at risk of MSUD. Let's move to the solid food introduction. Solid food introduction can be started at 4 to 6 months of age. And of course, it should be started gradually. First, you start with the zero protein containing food. And then after that, you can replace each 1 gram of protein from the standard formula by food So gradually, the standard formula will be decreased and replaced by allowed amount of protein from food. Once the patient grows, the monitoring, controlling the dietary compliance will be much more difficult, especially when they enter the school and find themselves different than others. So it's very important to incorporate such patients in their dietary planning and to provide the school or the nursery with a clear letter about their condition and their dietary management. These patients might have feeding problems such as slowness to feed, dislike of sweet foods, some developmental delay that might require GT insertion. At our hospital, we have 6 patients of MSUD that are on GT feeds. As I mentioned before, you have to provide these patients with higher protein intake during crisis, up to 3 grams per kg for patients from 0 to 3 years, and not less than 60 grams of protein in older patients, in order to prevent catabolism and to enhance the incorporation of the higher branched amino acid into new protein synthesis, which will not be achieved unless you have enough amount of other amino acids. Management of patients during illness is the same as the management of newly diagnosed patient. I have explained this in details before, but there is a point that was mentioned by Dr. Strauss and Dr. Al-Hasnan. If you cannot feed the patient immediately, you have also, and you have to do the dialysis, you have to do it in parallel with the enteral feeding. So whenever you have to provide an IV fluids and insulin, intralipids should be provided as well until the patient is able to reach the full feeds. Urine ketone monitoring is a useful way of detecting early crisis of these patients, and it can be utilized by the patients at home. We instruct our patient at home to delete the leucine from their dietary regimen once the patient is ill, or at least use only 50% of the allowed amount of protein, depending, of course, on labs. There is also an interesting guidelines for the management of these patients, which are there in the British Inherited Metabolic Disease Group website. And these are the emergency letters that we provide for our patient in regards to the dietary management. And I think Dr. Al-Hasnan has gone through them. At the end of this protocol, the patients will find the dietary emergency protocol for each disorder. For the liver transplantation, we had 17 patients who has undergone a liver transplant, and as a dietitian, I saw that their life was like their quality of life has improved a lot, because they are on regular diet. They don't have to bother about the restrictions, the dietary restrictions. They are more free, as Dr. Strauss mentioned. 4 of these patients are not from our hospital. They were transferred from another hospital, but we are following them as dietitians. Here are some useful websites and references. This is a picture of one of the awareness days that we have done for our MSUD patient. And here is one of our consultants that made a lecture in Arabic for the parents. And here is a picture of our lovely MSUD patients and their families. And this is one of our MSUD patients who is doing great, mashallah. And here is a list of my references. Thank you very much. Sorry if I took more time, and also sorry for the internet issues that I had. Thank you.
Thank you, Iman, very much for your nice presentation. And actually, I want to introduce our dearest lecturer, Dr. Nada Hamad. She is a lecturer of medical genetics, Department of Medical Genetics. She will present an interesting case presentation. Please, Dr. Nada, the floor is yours.
You are muted, Nada.
Still you are muted, Dr. Nada, still. Kindly no voice, Dr. Nada.
Is it clear, the voice now?
Yes.
Can you hear me?
Yeah.
Sorry, sorry for the inconvenience. Thanks for the fruitful presentations. They really helped a lot. I'm going to share my screen. Is it clear?
Yes, Dr. Nada, yes.
Can you see the slides?
Yes.
Yes. This presentation is about a family with two different metabolic diseases. As Professor Dr. Shalaf mentioned in her presentation, she talked about two different diseases in the same individual, but here there are two different metabolic diseases in the same family. This family was the first consanguineous couple who came to our genetics clinic 5 years ago with 2 days old male newborn. This one, the 2 days old male, they had a history, a family history of having 2 previous offsprings who died in neonatal period without diagnosis. The first baby was a female. She was delivered full term with average birth weight with uncomplicated perinatal history. She was admitted to neonatal ICU at the age of 7 days because of attacks of cyanosis. The patient suffered convulsions and was admitted till the age of 1.5 months, and unfortunately she died without diagnosis. The second baby was also a female who was delivered full term with average birth weight and uncomplicated perinatal period. She was admitted to neonatal ICU at the age of 6 days with abnormal movement and recurrent aspiration. She died also at the age of 12 days without diagnosis, but the mother, when she told us about this history, she stated that the second female was abnormal from the first female. The first female was normal till the age of 7 days, completely normal. But the second female, the mother noticed she was not that normal. She was not, she didn't say about a certain symptom that appeared on the child, but she was feeling she's not the same as the first one. The current baby they came with was a full-term male with uncomplicated perinatal period. Extended metabolic screening was done for him just for the history of the 2 previous 2 girls without appearing any manifestations for him. The extended metabolic screening showed elevated leucine, isoleucine, and valine, and this was suggestive and confirming of the diagnosis of MSUD. We started protein restriction, a special milk formula, and the patient actually, up till now, he's doing very well. He's growing. He's now about 6 years old. He has near normal levels. He has good control on protein restriction. He never had any single crisis of decompensation. He's doing great, and he's near normal regarding motor and mental development. 2 years later, the mother gave birth to another dizygotic twin, two male twin. They were both, of course, we withdrawn extended metabolic screening for both of them for the sake of the MSUD older sibling. We'll talk about them as twin 1 and twin 2. Twin 1 was found to have MSUD with extended metabolic screening. He also started MSUD formula once he was diagnosed, and he's doing okay. He has only subnormal mentality or mild intellectual disability and hyperactivity, but generally he's doing fine regarding motor development. He had only one attack of acute metabolic decompensation following a febrile illness. But the twin 2, who was found not to have MSUD at birth with normal levels of valine, leucine, and isoleucine, and was considered in the beginning to be the normal twin. On day 7 of life, the mother noticed that he has abnormal movement with frequent aspiration and started convulsions, and then was admitted in the neonatal ICU for 3 weeks on antiepileptics. Of course, all the neurologists and pediatricians who deal with this patient twin 2, everyone who sees him, he used to repeat the extended metabolic screening, and sometimes in another lab, they did not expect any other disease, while the older 2 siblings have already diagnosed MSUD. They just used to repeat extended metabolic screening every time they see the patient. Maybe it's not a severe case, maybe it's intermediate case, maybe this levels will increase with the convulsions or the encephalopathy of the patient or any neurological manifestations, but actually this did not happen. No elevation of leucine, isoleucine, or valine was ever detected in this patient. He lived for about 2 years with massive investigations. He was severely delayed regarding motor and mental development. Till his death, he didn't even have head support. He had convulsions all the time, which were poorly controlled on antiepileptics. This was the brain imaging of MRI brain imaging of the patient that showed extensive cerebroencephalomyelitic changes with symmetrical dilatation of supratentorial ventricular system. He also had the GERD with recurrent aspiration, and so was admitted a lot with aspiration pneumonia. The convulsions were poorly controlled. The patient died at age of 2 years with an attack of bronchopneumonia, but we managed to perform whole exome sequencing for this patient, as we believe that he has another condition. Whole exome sequencing revealed a homozygous pathogenic variant in the MOCS1 gene, confirming the diagnosis of autosomal recessive molybdenum cofactor deficiency. The older SIB, not the twin one, the older SIB with the MSUD, the one was originally diagnosed as MSUD. We also performed for him homozygous. We performed for him molecular study, and this revealed the homozygous likely pathogenic variant in the DBT gene, confirming the diagnosis of MSUD. This presentation illustrates the possibility of having 2 different metabolic disease in the same family due to the massive prevalence of consanguinity in our community. That's all. Thank you.
Thank you, Dr. Nada, for your nice presentation.
And now to conclude for our conference today, we have there are some changes we should do in our everyday treating of MSUD. Following patients with tandem mass is not the best thing to do, and we have to get an HPLC and measure amino acid properly. We should counsel again the patient and again about liver transplantation, as none of our more than 100 patients did a liver transplantation till now. Genotype phenotype correlation will be our next project, inshallah. Thank you, our guest speakers, our panelists, our speakers. Thank you all, and meet you next time, inshallah. Thank you. Now we'll close the conference. Thank you. Ola, you are muted if you like to say. Ola, you are muted.
I'd like to thank all, as Professor Saraf said, and hopefully next year we will be having face-to-face meetings and more about inborn errors of metabolism, and we can share all our experiences from all our Mediterranean as well as our international speakers, as we have been today. Thanks a lot and highly appreciating.
Yes, and thanks, of course, to Nutricia, who sponsored this meeting, and to IRIS conference for this nice collaboration and arrangement.